Well, thanks everyone. I can't tell if things have been sorted out with the breakout sessions and how they're designed. Let me see. Okay, it looks like we have the group who wants to be here, hopefully. So welcome. Please pay attention to the chat where my colleague from Health and Medicine, Anson Tong, is putting information about how to link with the AHA slides where we will have the discussion managed. I want to start again by thanking you for being here today. Talking about trauma and health, it can feel like the most obvious connection for folks to make when they think about trauma. We know that trauma impacts our physical health along with our emotional well-being. And we understand that looking at the Adverse Childhood Experiences study from the late 90s that really drew some firm connections between some early childhood experiences and later life health impacts and social impacts, that can point people directly to sort of a medical model and approach to addressing trauma. But we really want to kind of expand what we think about, when we think about trauma-informed health systems and healing-centered health systems. So, we know that the demands, the complexities, the inequities of our current health system are in themselves barriers to receiving timely care. They are sources for trauma for communities that are impacted. We know that being within a healthcare system, receiving treatment can feel traumatizing as well. It can be physically painful and frightening. And there can be feelings of a loss of autonomy, a loss of agency. So, we want to really think about how our health systems are designed, what kinds of environments they create for folks, what the experience is like for the workforce, for patients, for the larger community that's part of that community system with hospitals and healthcare organizations. So like I mentioned, we're going to use this AHA slides process to help facilitate this conversation. I think that we are a manageable size group enough that we can probably have some actual real dialogue as well. So to facilitate that, I'll be on the lookout for folks having your hands up as a way for me to know that you want to, you can either physically use your hand up or you can use the icon hand for me to know that you want to chime in with a question or with an idea. Please see the link that Anson has put into the chat. And then my ideas is going to help facilitate the actual conversation. So,
and am I doing the top one or the bottom one? Or are they the same?
I think they're identical. Yeah, they're identical.
All right, thank you.
So the first thing we want to know is, how would you define your role in the context of trauma-informed, healing-centered healthcare systems and outcomes? I'll give folks a second to weigh in on that. And you can think of your role as your title. You can think of it as the way that you engage with the system. You can think about it as the kind of organization you're at, and be as detailed as you want to be.
I just joined. That QR code is too small to scan.
Sorry about that. I'm not sure why it's coming out so small. Are you able to access the link ahaslides.com from a browser?
I'll try that.
Thanks, guys. I'm trying to troubleshoot a little bit of this tech issue on my end real quick, so I promise to be focused back on you in just a second. So who do we have in the room here? And please keep populating this. If you haven't shared yet. Your best defines your role. We have a facilitator of county level trauma informed change team. That's great, Gary. Can't wait to hear what you all are doing. Educator and researcher, a birth parent mentor, wonderful community supporter, activist, lifelong learner, another lifelong learner committed to supporting clients and colleagues. Yeah, and again, for this one, I want to make sure that folks are on the slide that reads at the top of it. What best defines your role in the context of trauma-informed, healing-centered healthcare? Oh, Myra, did we move forward on this?
No, it shouldn't have moved forward. Yeah, it should still be on this question, unless somehow folks accidentally skip to the next one. So they might be like reading the slide on the computer screen and seeing something else on, entering
All
something
right.
else in their phone.
What? Okay, sounds good. So, so maybe we could try, folks. Let's stick with the one. You can advance forward, but it'd be great if we could all just stay with the one piece for now. So I'm seeing things like community supporter and activist, local health department working with community partners, including schools, hospital, faith-based groups, funder. Yeah, if you could hold your thoughts on how you're defining things for now, bring them back to we're going to come back around to that in a little bit. Okay, has everyone had a chance to introduce themselves in this slide?
I don't know.
Yeah, this worked so beautifully this morning.
Yeah, and your answer, if you don't see your answer at this moment, it's probably up there. It's just for some reason, it's not letting me like scroll down to the rest of them. Because
Okay.
I do see answers being popped in, but I'm not sure what happened with the slide.
Okay. Well, thanks, Myra. Well, Myra, why don't we go to the next slide? Because it seems people are eager to
Yeah.
get into the substance of this conversation. So I'd like for folks to think about and stick on the slide that says, what word comes to mind when you hear the phrase healing centered in the context of healthcare systems and outcomes? So what word comes to mind? And if you type it onto this slide, we're going to see how folks are thinking about this space right now.
The browser's not letting us move to the next question. It's stuck on the, you already answered this question.
Myra, do you think we need to exit out and restart it?
No, I
If
think
you-
you can hit text and then, hold on, I'm gonna, no, that
Refresh.
doesn't work.
If you refresh your browser page, it works.
Paul, I feel the same way right now. I saw that frowny smile face coming up.
Refreshing it now, see if that helps. Okay, so now it's, okay, so I'm back to the first question. Go to the next one. Did it,
Okay.
when you are you all able to access this next question? If you go to, should either say like, go to slide at the top somewhere.
I'm sorry, I don't see any of that. I'm still in the AHA slide and it's the same question as before and it says I can submit multiple times.
Right, so at the top,
here.
somewhere near the top, do you see a button that says go to slide?
I do not have any buttons at the top. There's a presentation, like a little smiley face that I can click on. And then going back to the slide, there's no options for anything else. It's just, and then at the bottom, it says AHA slides, term tutorials, and I have the ability to kind of give a Likert scale, thumbs up to thumbs down.
Yeah,
Same
it's got the
thing here.
check mark saying the same question and you've already answered this question.
Yeah.
And
Yeah,
wait
mine-
for the presenter to show the next slide.
I'm so sorry. I don't know what to do.
Mine is showing a loading symbol.
Yeah, and I have that too.
Let me just go ahead and exit from the platform altogether and go back in. Sorry, give me a second.
Well, we're giving you a lot of time to think about what word or phrase comes to mind when you think about trauma-informed, healing-centered health systems. Necessary, holistic. Thanks, folks are starting to put that in the chat. That's a lovely idea.
Yeah, it's still giving me the first question.
Okay, I think I might have fixed it. So let's go back.
Y'all are wonderful for hanging in there with us.
Okay, what are folks seeing right now?
So first question,
Mm.
Okay,
Yeah, it's still the same one.
okay, let me advance to the next one.
all right, now we got what word comes to mind?
Okay, good. Seems like it's
And are you able to actually add into? Okay, I'm seeing some people are.
Yeah, I did move forward on the browser that time.
Okay,
Okay.
good. It looks like whatever Myra did fixed the issue. So thank you, Myra, for your persistence.
Yeah, now it moved. Thank you.
Oh, I'm so interested. When you hear the phrase healing centered, somebody put in condescending, entitled. I wanted unconditional acceptance, whole,
Prerequisite.
dignity, incompetent. So you could give folks a couple seconds, and I want to hear how people are thinking about the phrases that are coming up. What is resonating with folks? What might be surprising you?
Yeah, I see. Sorry, Bridget, as Sydney, I see healing centered as very forward thinking, you know, because I think sometimes we often think of trauma as so detrimental, and the word healing to me just really focuses on the fact that there's so much that can be done to impact it.
Thank you for sharing that, Sid. Would somebody else like to share their thoughts either on healing centered or what they're seeing coming up on the screen? I heard somebody speaking. Yes.
I shared peaceful, because for me, healing centered means having peace of mind. You know, knowing that someone cares enough to want to know what's going on with me. And as a dad and a father that works with many fathers and fatherhood groups and power of fathers and just everything fathers, especially when it comes to child welfare, that healing centered means peace that passes all understanding.
That's really beautiful. You know, what's interesting, I don't know if you were in the morning session, but there are several folks who are commenting on the importance of engaging fathers and wanting to see fathers to be more a part of our conversation around this work. So I'm so glad you brought that thread into this today. And then this idea of peace within healthcare, you know, that sounds like you were saying, you know, that you are listened to, that you trust what's happening, that you trust how your family will be treated, you trust how the folks you're working with will be treated is with respect and dignity. And that's a really beautiful sentiment. Would anyone else like to share?
Well, I'm again an architect, and I do healing environments for trauma, loss, and isolation. So I've worked with active military, with the veterans, the VA, and with inner city children. And what I have found within that, again, kindergartner through Vietnam combat vet, is a very fragmented system. What's kind of wonderful is you're seeing the transformation of trauma informed to healing centric. Trauma informed previously meant what you do not to trigger a PTSD response. Healing centered becomes, well, how do you heal people from trauma? Which, trauma informed is inherent to what healing centered is. So the language is starting to evolve, which is great.
I agree. It's kind of the difference between tolerance and acceptance, right? In cultural sensitivity and humility, we can all be trauma informed, but does that mean we're healing centered? I like what you said.
At least in our work, it's just part of the healing centered, because we did the Department of Veterans Affairs Healing Environment Design Guideline with 39 subject matter experts, including a lot of mental health experts and behavioral health researchers. And again, this guideline is supposed to be for hospitals, clinics, and outpatient clinic, or long-term living facilities. So we designed these healing design principles that go into the environment. And I'll just quickly say, environment brings everyone together, whether it's physical or virtual. It allows for this sort of integrative delivery of services, this sort of menu of choices. Because in this chat, you have so many wonderful services, but it may not always be appropriate for the particular individual or community. So that's what I'll quickly say.
I appreciate that so much, Paul. And I'd love it if you share that resource with us, that we would be happy to include it. I think people would be interested in us including that in our follow-up information with folks. And when you talk about environments, did I hear you say that you also think about it from an architectural standpoint, the design of the actual physical space?
No, we have designed the largest community-based veteran center in the country in Iowa, and the first standalone veteran center at Texas A&M San Antonio, as well as we worked at Bethesda Naval Military Medical Center. But my work and those environments are realized. So it's, again, how environment delivers your services in an integrated fashion. And it doesn't exclude art therapy, music therapy, performance, as well as peer-to-peer, group therapy, and individual therapy. So these are real places that have been built, and we are currently working with a Chicago public school on a well-being campus. I'm working with 180 kids who experienced trauma, loss, and isolation from the pandemic.
Well, thank you for sharing that, Paul. I would love to follow up with you.
Can I chime in before we move on to say?
Of course.
That I believe what Paul said was to the healing center to move to how do we help people heal from trauma, but it's how do we support them healing, not how do we heal them, because they have to do the healing themselves, not us. So just framing that language to say, how do we support them folks healing rather than how do we heal people from something.
But I think it's and or both. To your point, the self-help stuff, the mindfulness is very important. It's proving to be more effective than cognitive behavioral therapy. But they need guidance, especially in the terms of the initial traumas and the sort of being lost. And that's obviously what so many of you guys do. You do this wonderful work. And what this session does is hopefully bringing people together so you can work together, right?
Yeah.
But it's and or both. I found I've been doing this for 30 years, and it's not either or, it's and or both. There's lots of and or both.
Yeah, I want to reflect what Stephanie said, and then I see a hand up from Gary. Stephanie, I think that framing is really important too. And Paul, the processes you were talking about, but the idea of somebody else healing you is, I think Sid Wessel put in the chat, we all have different ways that we heal, and we might have different cultural ideas around how healing happens. And so if the frame is we're imposing something on you rather than we are asking you and reflecting with you on how healing happens, that's a real shift for a lot of people. And Gary, I saw your hand up, so I don't want to, yes.
Yeah, I just wanted to add, I think it's important to realize, like, I don't feel like we need to identify everybody with trauma and make sure they have therapy, as much as we all have triggers, and our triggers trigger their triggers when we react to them. And so really all of us becoming more mindful, more able to recognize and handle our triggers is going to help somebody else without any knowledge of what their trauma may or may not be.
I'm really glad that you brought that up, Gary. We talk about that in the trainings that we provide. We're not asking, folks in organizations, if they're not clinicians, or if they're not behavioral health staff, to ask people about their trauma history. We are asking folks, right, to recognize how it might show up in themselves, and to recognize that it might be showing up in how people are responding to the environment that they're in, and shifting those environments to reduce the likelihood that we're re-traumatizing people, and to increase the likelihood that we're providing healing-centered spaces, recognizing that because trauma is so common, we can assume that many of the people walking through our doors have experienced trauma. So a lot of you have weighed in on this poll. If you haven't yet, you can hopefully advance the slide to do so. Thinking about the word that you shared, how much does it actually align with what you're seeing? And I'm not surprised to see that somewhat is the big winner here. We know that folks have been, at this work. We know that there are a lot of bright spots. We know that there's really great and important work going to. Paul spoke to some of that. The not at all is, I also expected something around that. And then 5% saying they're very much saying that. So I want to hear from folks who answered that in many different ways. And so, Myra, maybe we can go to the next slide. And folks, I'll ask you to go to the next slide as you're managing your AHA. So I want to hear specifically from the folks who selected very or somewhat when they thought about that alignment between what you aspired for and what you were actually seeing. And, to think about and share with us if there were some specific actions that you saw that you either took, or your organization took, or your community took to make that true. And if you could share that right in the slide, that'd be great, so we can all see it. If you want to raise your hand and share it, welcome to do it that way too. Take a minute to think about it though. Elida, did I say your name right?
No, it's Alida.
Alida.
But the thing is, we're taking kind of like, I guess, a community-based approach and going to our police stations and feeding the people that are there.
Mm-hmm.
I didn't want to go personally. I made the food, but because there was no one to drop it off, I went. And the interaction with them, being bilingual and being a community health worker, right now I'm doing this all volunteer, kind of based thing. I just homelessness already. So I think the way that they're handling this, there needs to be some kind of there's no, I don't know, there's no process there. They're just sleeping on the floor.
Yeah.
When you go to the desk, they're very non-informative, the people that are working behind the desk.
Mm-hmm.
And the interaction there, they're like, oh, well, if you know Spanish, you can ask them what they need. I'm like, wow, wow. You know what I mean? I'm saying hello and they're not saying, it's like they're disgusted themselves,
Mm-hmm. Yeah.
And I saw what was happening. And I think I'm just going to take more action, being that I can interact with the people that are here,
Yeah.
and helping them. I was trying to, it's already hard knowing both languages and defending myself,
Yeah.
but the thing is not knowing, I said, I was trying to explain to them, like, learn English, do you have IDs, what does you need? And then just kind of interacting with other people that I know and seeing, we're going on a daily basis. Everyone has a schedule. So we have donations going. So it's a little bit of everything. It's in our neighborhood, so I think that's a good thing. It's a good thing.
It is a good, yeah, the sort of mutual aid that is responding for the lack of a holistic and healing centered response from our public institutions has been essential. We saw that in COVID emerge as a really strong strategy. And it's unfortunate that, that the experience that you have in interacting with the folks within those systems is, makes it clear that the folks who are in those environments are not only just sleeping on floors, but potentially in environments that are hostile or not welcoming at this moment.
Yeah.
And
So I got some extra masks. I'm gonna take them, because remember the interaction before, and being a contact tracer, I've literally, learned so much, like epidemiology. I've learned thinking about what falls upon, in groups of people, look at, we never thought this was gonna happen. But if you really look at everything that's happened in the past, it's just kind of like a cycle, and hoping that, just everything just, I don't know.
well, thank you for sharing that. It's
Thank you.
very timely and very much appreciated. I'm also seeing folks talk about harm reduction, starting with listening, learning from, and elevating disproportionately impacted populations. That is absolutely critical to the work. We say there's no trauma-informed and healing-centered work without racial justice and without dealing with inequities head on. Somebody shared that at their FQHC, they have extensive but limited services. So they have to refer out to other systems that are less caring, more traumatizing, financially opaque. So you can try your best, but you're still operating within a broader ecosystem that that traumatizes the folks that you're working with. That's a real reality for a lot of our organizations that we partner with. Some things that folks have seen to help with alignment, multiple training opportunities, but no systemic review. Yeah, we see that a lot too, right? So you can train staff, you can train the workforce, but if you're not looking at the policies that inform how a system or organization, a hospital, a clinic, how they operate, how they treat their workforce, how the policies dictate decisions made for the folks who are walking through those doors, there's only so much that somebody who's trained in these concepts can do within that broader system. I'm seeing somebody say in health and public spaces, you see important reframing of saying race as a risk factor to saying racism as a risk factor. Yes. So we have talked about this at the collaborative. It is the thing, the ism, right, that creates the risk, the bias that creates the risk, and not that person's identity itself that creates the risk.
Well, I'm sorry, Bridget. That sounds like a broad statement, and isms are usually what trigger people to operate in a mindset that they might not normally operate in when it comes to race.
Thank you. And thank you for sharing that. I want to, I think what I'm thinking of is, we are wired to think about who's responsible for their circumstances, for their health and well-being. And if we point to, somebody's identity, somebody's ethnicity, somebody's race as a risk factor, it's a frame and cueing around that being the thing that causes risk versus how other people perceive that identity, that culture, that race as being the thing that actually creates risk.
And both those mindsets can be problematic.
Sure.
If they become systemic. So. But thank you.
Yeah. No, thank you for sharing that. I'm seeing some things that are taking place are multiple harm reduction programs in our community, but limited partnership with healthcare providers. I'm interested in hearing about this, this idea of how community-based organizations, how community organizations are able to or not able to interact with healthcare. I wonder if anyone would like to speak to that.
I can tell you that our local hospital did not know what to do with a person with mental illness and came to us and asked us. And we're like, well, look, just let her sleep for a little while. Let her get her sleep, because when she wakes back up, she'll be clear, you know, just like the importance of peer work in the emergency room and the hospital systems. The nurse was like, she won't talk to me. She won't tell me her name, you know, and we're like, look, give her some crackers, give her some water, let her get a nap and give her about a half hour. And when she wakes up, that psychosis, we know, we worked with her, and it's not substance use, it is straight mental illness. And they were just going to release her onto the street because they didn't know what to do with her, which was going to in turn put her into the justice system, which they released her because they don't know what to do with her there either. So just kind of being able to have the peer workers involved, to know those people, to know what they need help with, versus I don't know what to do, let me give her to somebody else, you know, just to be there and be present and not even think, well, this is mental illness, so let's refer her to the mental illness hospital that's 20 miles away. You know, just there's not we're very small and very rural, and there's a lot of stigma and a lot of assumptions being made. And so it just really very much felt at that point, well, you know what, I don't know what to do with her, so let's just let her go, someone else will.
And
You know?
Alita, just to build on your point, one of the biggest, at least in urban hospitals, one of the biggest accomplishments the hospitals have seen is creating a padded room in the emergency room, where they throw the the person having a mental health crisis into a padded room with no windows, like, I mean, a jail cell. And they feel that that's going to take care of the problem, which in fact, and we're talking about trauma informed now, that kind of captivity, that kind of ultraviolet, blue light with padded walls, in fact, stresses them out more and creates a bigger problem.
So I want, thank you. And I am just noticing the time because I was so wrapped up in the conversation. Myra, I want to see if we can get to the last question that we asked folks. We can skip this one, and this one, and this one. I was very ambitious about how many questions we would want to answer today. I do want to hear from you in the context of healthcare and health systems. If you could implement one change to make your community's healthcare systems be more trauma-informed and healing-centered, what would it be? I'll let you guys take a minute to think about that and add it in to this slide. And if there's time, we'll see if there are any themes that emerge. Think of people as people. Recentering our humanity is a pretty important piece of this. Universal single payer healthcare, single payer health insurance. We think about that and how the medicine is obviously better for our community members and for patients, but what might that look like for our workforce, which is bogged down with these, very complicated fee-for-service models that they have to address. So looking at that back end as well. Non-judgmental, Alita, thank you. Healthcare first, insurance second, listening to what they have to say, mandatory dedicated funding and training for trauma-informed care. Who said that? I want to give that a thumbs up right now. We have way more interest in learning more about this, then people tend to have capacity to actually dedicate and focus time and staff resources. So it's often something that becomes an add-on for a staff person because they're really passionate about this work, but it's not core to their job. So, how are we burning out our own field because of that? Okay, well, I want to, these are all really great ideas. I want to take just one, people are still typing, but I want to take 1 second for folks because we got to go back into the room. Actually, let's skip the voting part. There are no bad ideas here. I want to give people every chance to add their ideas. Right, require anti-bias training. I think about that a lot with healthcare and with the disparities in maternal child health outcomes, for example, for Black women and women of color in particular. We'll actually be co-hosting a screening of a documentary called Birthing Justice with some partners in Chicago that looks at, opportunities for improving birth outcomes for birthing parents and for their infants, for Black birthing parents in particular, and for their infants. So we'll be sending that information in a follow-up. We would love to have folks attend that event.
I see a lot of training available, but not accountability held in those systems.
Yes, I agree. So this, that trainings people come in and be trained, but what's the follow-up? How do we know that there's any uptake from that knowledge gain? What support are people getting to actually implement what they're learning about? So I thank you so much for raising that. Well, I think it is time for us to head back to the main room. Thanks for hanging in with us for a bumpy start on the tech. Really appreciate it. We'll come back to the main room and do a quick debrief with folks. Thank you.